He may even identify himself with it and believe that he is what he appears to be.
Welcome to the NCE Study Guide, a special deep dive. We're so glad you're joining us today.
Great to be here.
So this is a study group summary from July 8, 2025. And a big shout out to Angela, who inspired this session.
Yeah, thanks, Angela. Always great topics coming from the group.
Definitely. Today, we're diving into the essential world of assessments and diagnosis and counseling. And we're going to use a truly fun and relatable case study. It really helps uncover this truth. Diagnosis isn't just about labels, it's about seeing the unseen and guiding transformation.
That's a perfect way to put it.
Okay, let's unpack this fascinating area because, understanding how counselors approach client needs is absolutely crucial.
It truly is foundational.
Yeah.
I mean, diagnosis isn't just some clinical formality, right?
Yeah.
It's about really understanding a person's unique challenges, validating their experience, and then guiding them toward effective support.
So it's dynamic.
Very dynamic. It's woven right into the fabric of therapy itself.
Okay, that's a crucial point. To make this really stick, let's dive into a fantastic case study we've cooked up.
All right.
Imagine a cozy coffee house in New York. Central Perk. Yes, that's Central Perk, where Dr. Greenfield, a licensed professional counselor and registered art therapist, is leading a unique art therapy group.
A perfect, maybe even iconic setting for this kind of personal exploration through creativity.
Exactly. And the group consists of 6 close friends we all know: Rachel, Ross, Monica, Chandler, Joey, and Phoebe, all sort of navigating the ups and downs of adulthood.
The usual struggles.
Yeah. And the core idea is exploring their personal challenges through creative expression, with Dr. Greenfield applying careful assessment and, diagnostic considerations throughout the whole process.
Makes sense.
So let's start at the very beginning. Scene 1. The initial conversation. Before the group even officially kicked off, Dr. Greenfield met with each participant individually. This seems like a critical first step. Why is this one-on-one intake so important, especially before a group setting?
Well, these early conversations are vital. They help counselors form their very first clinical impressions. It shapes how they approach the group dynamics and also each individual within it.
Okay.
Dr. Greenfield actually used a structured diagnostic interview, specifically something called the MINI. That's the MIDI International Neuropsychiatric Interview. It's often used to, quickly screen for major psychiatric disorders.
So it gives an initial snapshot?
Exactly. Just an initial snapshot of potential concerns.
And what a snapshot she got. For example, Rachel seemed pretty restless and distractible during her session.
Okay.
Ross, well, as you might expect, talked a lot about his recent divorce stress.
Right.
And Monica, always so precise, she discussed her history of disordered eating. So these pre-group meetings really laid the groundwork, huh? Gave her those initial data points.
Precisely. Those initial structured clinical interviews and assessments provide crucial data. It informs the whole therapeutic process that follows, helping the counselor really tailor their approach.
Okay, that makes sense. Moving into scene 2. First strokes on canvas. So during their very first group session, Dr. Greenfield asked the members to draw a safe place.
The art therapy component.
Yeah, this is where it truly began to shine.
And the results, I bet, were so telling.
Totally. Phoebe, for instance, created this abstract mix of celestial colors. It hinted at a really unique internal world, maybe one that's kind of hard to verbalize.
Potentially. Nonverbal expression.
And Joey, classic Joey, drew himself with a sandwich, his safe place, naturally.
Of course. Very Joey.
And Monica's image was, well, unsurprisingly, very precise and symmetrical, really reflecting her internal world of order.
Yeah, that tracks.
Okay, here's where it gets really interesting. So the art itself isn't just a pretty picture. It's actually a window into their world, right?
Absolutely.
But how does Dr. Greenfield make sure she's accurately, reading what that window is showing her? It seems subjective.
That's a great question. And you're right, interpretation needs care. She wasn't just admiring their drawing skills. She was observing their effect, how they expressed emotion while drawing and talking about it, and the symbolic content of their artwork.
Right.
These creative expressions, they're often called projective assessments. Combined with just watching them, the behavioral observations, they really supplemented her clinical impressions from the interviews.
So it adds another layer.
Exactly. The art provides this nonverbal narrative. It lets her gather insights beyond what a purely verbal interview might reveal, especially for things someone finds really difficult to articulate directly.
Which brings us neatly to scene 3, the art of careful diagnosis. This is where the complexities really start to bubble up. Ross, for example, he shares that he hasn't been sleeping well and feels kind of numb since his divorce.
Right. And what's fascinating here is that Dr. Greenfield didn't just jump to conclusions. She consulted the diagnostic criteria, like those found in the DSM-5-TR.
That's the big manual, right? The Diagnostic and Statistical Manual of Mental Disorders.
Yep, that's our profession's key guide. She looked at the criteria and considered whether his symptoms met the criteria for, say, an adjustment disorder or perhaps even major depressive disorder.
Okay, so weighing possibilities.
Exactly. She understood the importance of differential diagnosis, that process of weighing different possibilities. And crucially, she held off on a definitive diagnosis. She made it a provisional diagnosis.
Provisional. Why?
Because she knew she needed more data, more time, more observation to be really sure.
That provisional aspect is interesting. So it's not about being indecisive, it's more about, like, ethical rigor.
Yeah.
How does being cautious actually protect the client in practice?
Oh, it absolutely protects the client. By making a provisional diagnosis, Dr. Greenfield avoids mislabeling Ross prematurely. That could lead to the wrong treatment or cause unnecessary distress.
Yeah, that makes sense.
It gives her the time to collect more information, ensuring that when a definitive diagnosis is made, it's as accurate and helpful as possible. It's all about gathering sufficient evidence to ensure accuracy. That's paramount in avoiding misdiagnosis.
Okay, got it. So fast forward to scene 4, checking in and checking progress. At the halfway point of the group, Dr. Greenfield didn't just keep going. She actually conducted standardized assessments.
Smart move. Reassessment is key.
Yeah, specifically, she used the Beck Depression Inventory, the BDI-2, that's a common self-report for depression symptoms.
Very common, yes.
Blah.
Widely recognized.
And the GAD-7, which screens for generalized anxiety.
Good choices for common concerns.
And the results were pretty insightful. Rachel scored high on inattention and anxiety, which kind of aligns with those initial observations of her being restless.
Okay, consistency there.
Monica showed reduced anxiety, which is progress, but she was still struggling with perfectionism. But what's really interesting here is what happened with Joey.
Uh-oh.
She basically joked his way through the responses on the assessments.
Oh, Joey. So how did Dr. Greenfield handle that, especially when it comes to the integrity of the assessment itself?
Yeah, exactly.
Well, it highlighted a really crucial concept: validity in self-report measures. His joking meant she needed to seek clarification, maybe talk to him about it, to ensure that the tools were actually measuring what they claimed to measure for him.
Right.
If someone isn't taking it seriously, or maybe they're intentionally trying to present themselves a certain way, minimizing or exaggerating the results might not be valid. They don't accurately reflect their current state.
So the counselor isn't just a data collector.
Not at all. They're a skilled interpreter, bringing context to those numbers. You can't just take the scores at face value.
That's a really important nuance. Wow.
Exactly. It really underscores the counselor's critical role in interpreting data, not just collecting it.
Okay. And finally, scene 5, clarity and next steps. By session 10, Dr. Greenfield had a much clearer picture. She was able to make some key conclusions.
Right. The culmination of the process.
Yeah. Phoebe's trauma history and her hypervigilance, for example, really aligned with PTSD. This led to a referral for individual trauma-focused therapy.
Appropriate next step.
Yeah.
Specialized care.
Joey, while still, playful Joey, showed symptoms consistent with undiagnosed ADHD.
Interesting. Worth exploring further.
And Ross was formally diagnosed with adjustment disorder with depressed mood.
Okay, so she landed on adjustment disorder after gathering more info.
Exactly.
And this stage really demonstrates the importance of sharing the diagnosis, but with informed consent. The client needs to understand what it means and how it impacts their treatment plan.
Right, it's collaborative.
Absolutely. And it also showcases trauma-informed assessment, especially with Phoebe, approaching potential trauma with sensitivity and knowing when specialized referrals are needed.
So it really is a dynamic journey, isn't it? Understanding someone's mental health is not just a single snapshot.
Not at all.
It's this ongoing process of gathering information, reassessing, and then forming a comprehensive plan for support.
You nailed it.
That case study, wow, it really showed us how these concepts play out in real life, didn't it? Using familiar characters makes it click.
It really does. It makes abstract concepts much more concrete.
But now, let's pull back a bit and look at the bigger picture. Why is this entire framework of assessment and diagnosis not just important, but absolutely vital for every counselor and really for every client they serve?
Fundamentally, accurate assessment and diagnosis ensure ethical and effective treatment. That's the bottom line. It clarifies what the client actually needs. It guides the interventions we choose, and it aligns the services with best practices.
So it gives direction.
Exactly. Think about it. Many clients come in feeling lost, maybe confused, not knowing what is wrong or why they feel the way they do. Our GPS, so to speak, isn't just finding a label.
Right.
It's validating their experience, giving them a language for their struggle, and maybe most importantly, showing them there's a path out, a way forward. Without it, you're essentially, well, flying blind.
And the risks of flying blind are serious, right? Misdiagnosis can truly harm clients.
Oh, absolutely. It can lead to inappropriate treatment, wasted time and resources, maybe even unnecessary stigmatization.
Yeah.
It can waste valuable time, financial resources, emotional energy, and potentially worsen a client's condition if they're not getting the specific, targeted help they actually need for what's going on.
Okay. So how did we even get here? Like, what's a bit of the history behind these assessment tools and these diagnostic guides like the DSM?
Well, the roots of assessment tools really trace back to psychometrics and the medical models, mainly from the 1950s to the 1970s. But a huge turning point was in the 1980s when the DSM-3 came out.
What changed with DSM-3?
It introduced standardized diagnostic criteria. That brought much-needed consistency to the field. Before that, it was a bit more subjective.
I can imagine. Consistency makes a huge difference for research, for treatment.
It truly was a game changer. Then, later versions, the DSM-IV in 1994 and the DSM-5 in 2013, expanded those considerations further. They started including more about cultural and developmental factors, acknowledging that people's experiences are diverse and shaped by context.
That seems really important.
Crucial. And the latest refinement, the DSM-5-TR, which came out in 2022, added even more nuance, particularly around things like trauma, grief, and neurodevelopmental disorders. It reflects our evolving understanding.
Wow, that's a lot of evolution. It can feel overwhelming trying to keep it all straight. For those of us trying to get a handle on it, how can we break it down simply? I love a good analogy.
Okay, how about this? Let's think of assessment like using a GPS for therapy.
Okay, I like that.
GPS.
Your initial interview with a client. That's like pulling up the map, getting a broad overview of where they are and where they might need to go. Their general journey.
Got it. Big picture.
Then the specific tests or questionnaires you use, like the BDI-2 or an ADHD screener, those are like the road signs along the way. They give you detailed, specific information about what you're encountering right now. Depression symptoms, moderate. Attention difficulties present.
Okay, specific markers.
Right, and the diagnosis. That's like
Yeah.
your final destination or maybe a key waypoint. It's the clear point you're aiming for to get them the right kind of help, the right support. That analogy really makes it click. It's all about navigating effectively to get to the right place for the client.
Exactly.
And if your map is outdated, like using old criteria, or your road signs are misread, like misinterpreting test results,
you won't reach the right destination, or you'll take a much harder route. You won't get the right help, and that is a real risk.
makes perfect sense.
It just underscores the importance of accurate, updated information at every single step.
Okay. Now, thinking specifically about the exam, for our listeners who are studying for the NCE, how might this whole topic assessment diagnosis actually show up?
Well, you should definitely expect questions where symptoms are embedded in case vignettes, just like our central perk scenario.
Right, like the examples we used.
Exactly. They'll describe a client, list some behaviors or feelings, and then ask you, what diagnosis seems to fit best? Or what assessment tool would be appropriate to use next? Or what should the counselor do next?
Okay. Can you give an example?
Sure. Let's say a vignette describes a client presenting with difficulty concentrating, impulsivity, maybe restlessness. The question might be, what is the counselor's most appropriate next step?
And what's the kind of thinking they're looking for there?
The best answer would likely be something like, administer a validated ADHD screening tool and collect collateral information. It emphasizes that cautious, structured reasoning.
Not jumping to conclusions.
Precisely. Not just diagnosing based on a few symptoms, but taking the next methodical step to gather more evidence.
Okay, that's helpful. So, keeping the big picture in mind, can you walk us through the typical flow of this process from start to finish, like the main stages?
Yeah, you can think of it as a systematic flow. First is the initial interview. That's where you build rapport and do an initial symptom check.
Okay, step one.
Then you might move to standardized tests or other formal assessments to get more objective, evidence-based information.
Step two, gather data.
Right. This data, along with the interview and observations, leads to the diagnosis, which hopefully clarifies the primary issues,
Step three, formulate the diagnosis.
which then directly informs the treatment plan. That's step 4, what are we actually going to do in therapy?
Makes sense.
And it doesn't stop there. Step 5 is reassessment. You need to track progress, see if the treatment is working. And step 6, if needed, is referral for specialized support, like the trauma therapy for Phoebe.
So it's kind of a cycle.
It's often a continuous loop, yeah.
Yeah.
All aimed at promoting the client's well-being.
Got it. Are there any common subtypes or related models within this whole area that people should be aware of, like different kinds of assessments or diagnoses?
Definitely. For assessment, you'll hear about structured versus unstructured interviews. Structured ones have specific questions, unstructured are more conversational. And formal versus informal assessment. Formal means standardized tests. Informal could be observation or reviewing client journals.
Okay.
Then within the DSM-5-TR, disorders are grouped into broad categories. Things like neurodevelopmental disorders, like ADHD, trauma and stressor-related disorders, like PTSD, adjustment disorder, mood disorders, anxiety disorders, and many others.
And what about those diagnostic terms like provisional?
Right, those specific concepts are key. We mentioned provisional and temporary diagnosis. There's also rule out, where you consider a diagnosis but decide against it based on the evidence. Comorbid means having 2 or more disorders at the same time. And differential diagnosis, which we talked about with Ross, comparing possible diagnoses to find the best fit.
Those distinctions are super helpful for clarifying things. Okay, this is a lot of information. Any practical tips for retaining all this, especially for folks prepping for the NCE?
Sure. I really like using mnemonics for remembering processes. For the assessment phases, maybe something like I see Doctor.
Okay, what does that stand for?
Interview, screening, evaluation, establish diagnosis, develop plan, and reassess. I see Doctor.
I see Doctor. That's actually brilliant. Interview, screening, evaluation, establish, develop, reassess. I like that.
Hopefully it helps. Also, good old-fashioned flashcards for symptom lists for major disorders can be incredibly effective, just drilling the key features.
Right.
And if you're studying with others, role-playing diagnostic interviews is fantastic. One person is the client, one is the counselor. It really helps cement the process and how to ask questions.
Great tips. Okay, so to sum it all up then, if you had to boil it down, what do our listeners really need to know about assessment and diagnosis as they move forward?
Okay, key takeaways. First, remember diagnosis is a process, not just a static label you slap on someone. It evolves.
Right, dynamic.
Second, you must use multiple data sources, interviews, tests, observations, maybe collateral info to get a comprehensive picture. Don't rely on just one thing.
Triangulate the data.
Exactly. Third, always consider cultural, developmental, and trauma-informed perspectives. These profoundly impact how symptoms are expressed and understood. It's not one size fits all.
Crucial.
And finally, critically, always pair any diagnosis with a clear treatment plan and a referral plan if needed. The diagnosis should guide action.
Makes perfect sense.
Yeah. Indeed. It's really about using every tool at your disposal. From those careful conversations to the structured assessments to create a clear path forward for well-being for your client. You don't have to memorize every single disorder in the DSM. That's overwhelming. But you do need to understand how to think diagnostically.
How to approach it.
Yeah. Use curiosity, always use ethical caution, and rely on clinical structure. Honestly, you're already building that muscle just by engaging with this deep dive.
Awesome. Okay, we've walked through the theory, we've seen it in action with our friends at Central Perk. Now, let's solidify that knowledge. Time for a quick practical application.
Let's do it. Quiz time.
We've designed 5 NCE-style questions to challenge your understanding of what we just covered. Get ready to test your diagnostic muscle. You ready?
Ready.
Okay. Question 1. Dr. Greenfield notices that Joey's artwork lacks detail and his attention often drifts during group sessions. He also jokes excessively and frequently interrupts others. What should Dr. Greenfield do next? A. Diagnose him with ADHD immediately based on these observations. B. Use a validated ADHD screening tool and gather more developmental history. C. Refer Joey to a psychiatrist for medication without further assessment. D. Wait and see if the symptoms continue over the next few sessions.
Okay, thinking through those.
So the question is, what's the immediate next step?
The correct answer here is B. Use a validated ADHD screening tool and gather history.
Why B?
Well, what's fascinating here is that while the symptoms Joey presents are definitely suggestive, maybe indicative of ADHD, ethical diagnosis requires more. You need structured tools, and you need to gather more comprehensive information like developmental history, maybe collateral from family if possible, to build a full picture. Jumping straight to A, diagnosis, or C, referral without more assessment is premature. And D, waiting, might delay getting needed support if it is ADHD. So B is the most responsible next step. Makes sense. Gather more data methodically. Okay, question 2. Monica scores quite high on the BDI-2, indicating significant depressive symptoms. However, in session, she insists she feels fine now and downplays her score. Dr. Greenfield starts to wonder if the test results are accurately reflecting Monica's state. What concept is most relevant to Dr. Greenfield's concern here? A, standardization, B, validity, C, reliability, D, comorbidity.
Interesting situation with Monica.
Yeah, the score versus what she's saying. What concepts does it play?
But the correct answer is B, validity.
Explain validity here.
So validity refers to whether the assessment tool is actually measuring what it claims to measure accurately. In this case, is the BDI-2 score a valid reflection of Monica's depression level? If she's minimizing her symptoms, maybe due to social desirability bias wanting to appear fine, then the test results might lack validity for her in this instance. So the score might be numerically high, but not truly representative.
Exactly. Reliability C is about consistency of the test. Standardization A is about uniform procedures, and comorbidity D is about co-occurring disorders. Validity is the core issue when there's a mismatch between the score and the clinical presentation or self-report.
Got it. Okay. Question 3. Ross reports persistent sadness, difficulty sleeping, and loss of interest since his divorce several months ago. Dr. Greenfield considers both adjustment disorder with depressed mood and major depressive disorder as possible explanations. What diagnostic process is she engaged in? A, making a rule-out diagnosis. B, using a projective technique. C, conducting a differential diagnosis. D, avoiding diagnostic labeling altogether.
Thinking about Ross's situation.
Yeah, she's weighing 2 different possibilities. What's that called?
The answer is C, conducting a differential diagnosis.
Tell us more about that.
If we connect this to the bigger picture we discussed, differential diagnosis is exactly this process. It involves systematically comparing the symptoms of 2 or more disorders that have overlapping features to determine which diagnosis provides the best fit for the client's unique presentation. She's differentiating between adjustment disorder and MDD based on criteria like timing, severity, and specific symptoms.
So it's like comparing and contrasting diagnoses.
Precisely. A, rule-out, is related but implies deciding against one. B, projective, relates to tools like art therapy. D, avoiding labels, isn't accurate because she is considering labels, just carefully.
Okay, differential diagnosis it is. Question 4. Phoebe's artwork consistently includes dark imagery and erratic brushstrokes. In session, she shares a history of significant past trauma and describes experiencing sudden panic attacks and feeling constantly on edge. What should the counselor prioritize as a next step? A, administer the MMPI-2 immediately to assess personality factors. B, diagnose PTSD immediately based on the art and self-report. C, discuss a referral for specialized trauma-focused therapy after conducting a thorough trauma-informed assessment. D, ignore the imagery for now and focus only on the present panic symptoms.
Okay, Phoebe's case requires sensitivity.
Absolutely. What's the priority?
The correct answer is C. Refer for trauma-focused therapy after trauma-informed assessment.
Why so?
Well, option A, the MMPI-2, is a broad personality inventory. It's not the most immediate or targeted step for suspected trauma. Option B, diagnosing immediately, again, skips the necessary comprehensive assessment. Option D ignores critical information. The trauma history and art themes are likely connected to the panic. So C raises the important point. How do we approach sensitive client info like trauma?
Right.
Ethically, suspected trauma must be addressed with care. That means a thorough trauma-informed assessment first, respecting the client's pace and safety, and then discussing appropriate referral to specialized care, like EMDR or TFCBT, designed specifically for trauma.
Okay, so assess carefully, then refer appropriately.
Exactly. Sensitivity and specialized care are key.
All right, last one, question 5. Rachel reports significant difficulty focusing during group, frequently loses her train of thought, and mentions struggling to complete tasks at work. What type of assessment would provide the most structured and specific insight into these particular difficulties? A standardized attention and concentration inventory, for example, CPT, brief. B, a narrative therapy exercise exploring her life story. C, an art-based projective tool focusing on task completion themes. D, a personality test like the Myers-Briggs Type Indicator, MBTI.
All right, focusing on Rachel's attention issues.
Yeah, needs structured insight into those specific problems. What tool fits best?
The answer is A, A standardized attention inventory.
Why A over the others?
Standardized inventory is specifically designed to measure attention and executive functions, like continuous performance tests, CPTs, or behavior rating scales like the brief, offer reliable and valid data about these specific symptoms. They provide a structured way to quantify and understand the severity of the attentional difficulties she's reporting.
And the others.
B, narrative therapy, is great for exploring meaning, but not for quantifying attention. C, art-based, can offer insight, like we saw, but it's less structured for specific symptom measurement of attention compared to a standardized test. And D, MBTI, measures personality preferences, not clinical attention deficits. So A is the most targeted tool for the question asked.
Got it. Standardized tool for standardized data on specific symptoms. Okay, quiz complete. Hopefully that helps solidify things for everyone listening.
Yeah, applying the concepts really helps.
Absolutely. This deep dive, wow, it's really shown us that assessment and diagnosis and counseling isn't just about sticking labels on people. It's truly a dynamic, ethical process. It's about understanding and supporting individuals, like our Central Park friends, Rachel, Ross, Monica, Joey, Chandler, and Phoebe. It's really about helping someone find their path forward, giving them a language, maybe, for their struggle, and showing them there's a way through it.
Indeed. It really is about using every tool you have, from those careful, empathetic conversations to structured, evidence-based assessments, all to create a clearer path forward towards well-being.
Yeah.
And maybe this raises an important question for you, the listener, to think about. How might integrating these assessment principles, careful observation, seeking multiple data points, considering context into your own thinking, help you understand others, or maybe even yourself, more deeply, going beyond just seeking a simple label?
That's a great question to ponder. You know, you're building an incredible muscle just by engaging with these complex concepts. And if you found this deep dive valuable today, please consider giving us a 5-star rating wherever you listen. It really helps others find the show.
It does make a difference.
And to keep these study sessions going, get access to summaries like this one, and join our fantastic community, consider joining the Deep Dive Study Group via Patreon. Your support genuinely helps us create more content just like this, tailored specifically for you and your learning journey.
We appreciate the support.
We really do. Until next time, keep exploring, keep learning, and keep diving deep.
1, 2, 3.
Nice to be in orbit.